That leads us into the next session, which is, that was the governance, and you could tell a lot of hospitals are in the process of implementing the standard, and certainly St John of God has made significant progress, but still has challenges in front of them. The next one is to actually highlight the successful implementation of a PBM program, which is a claim that I'm certainly keen to see translated across the rest of the country. We're very lucky to have Dr. Peter McCall here, who's the head of Clinical Operations Department of Anaesthesia in the Austin Hospital. Peter's main clinical interests are liver transplantation and major cardiac and aortic surgery. His long-standing interest in haematology and transfusion medicine in the operative setting. Has a major medical role in pre-operative assessment and optimisation of patients' blood. In conjunction with Austin Haematology, he set up pre-operative hemoglobin optimisation at Austin. He is also currently completing a Master's in Health Management. Thank you very much, Peter.
Rather cheekily, you didn't actually say that whilst Larry goes to all the committees, I'm at the Austin doing the work. Probably all of you work in hospitals that are adorned with brightly coloured posters at the moment. Perhaps this might be more appropriate for some of you. The background and the evidence that supports patient blood management has already been covered, so therefore I don't need to cover it, except to make the point that in the guidelines and the criteria, patient blood management doesn't specifically sit as a criteria in its own right. It sort of is vaguely encompassed in probably 3 out of the 4 criteria. Importantly, the accreditation gives us a means to implement what we've always known for a long period of time is good clinical practice, and it's accelerated our process at the Austin. And as has been referred to repeatedly today, certainly when we had our interim accreditation assessment, it pushes the concept of audit so heavily, which I will get to later. So obviously we've heard that blood management relates to hemoglobin optimisation, blood conservation and tolerating an anaemia, and is a broad sense that requires the establishment of the process, the education of those involved, and, as I will say it so many times, the importance of audit. Now, I'm, I suppose, a senior manager at the Austin. I have sat at so many redesign meetings, and it's interesting now that I'm doing my Masters that there's a lot of evidence and information that says that what we actually do in these redesign meetings is actually probably flawed. So what I want to share with you is with concepts of implementation clinical change is perhaps some of the repeated things that we go through are not necessarily correct. One thing is that restructuring is omnipresent in healthcare. We have a problem. What we do is we restructure, we devise a new process to correct the problem. Now, this article makes a very strong ploy that, in fact, it's reached the point that restructuring is at the gratification of those who do it, and in fact, we should invest in our existing processes and redefine them. And so, therefore, for me, who wanted to get involved in a successful process at the Austin, I looked at what our existing structure was, and clearly, through our anaesthesia clinics, we have a pre-operative optimisation process that perhaps in the past hasn't included hemoglobin, but has involved lots of other areas. A fundamental resource that we have is our anaesthesia resource nurses who assist the anaesthetist in that pre-operative optimisation process. So it didn't seem logical to me to create an anaemia clinic to correct or to assess pre-operative hemoglobins. However, what I should have included here is what we also did have was an outpatient structure with the haematologist. So it's important for us to link our anaesthetic pre-operative assessment with our existing haematology outpatient process. The other really important concept that I've been exposed to whilst I've been studying is the realisation that healthcare is provided in a system. Unfortunately, conventional medical, probably nursing, probably all allied healthcare is in a traditional model that is not actually focused on the system. It's actually focused on the accumulation of knowledge, the holy sanctity of the individual relationship between practitioner and patient. And in that scenario, improvement is slow, healthcare improvements are limited because you're relying on consistency of individuals, which is difficult. And there has been the sniggerings in the room about VMO attitudes and medical attitudes, and there is certainly one fundamental concept that medical staff need to actually accept, and that whilst they give medical care to individual patients, they actually don't do it in a vacuum. So therefore, if I want to get successful change, I can't design a process that's going to rely on the individual doctors to change their practice. I have to come up with a better system. So therefore, it's important for me to put in place a process that was consistent, reproducible, and therefore we could monitor it. So if you look at these concepts of pre-operative hemoglobin optimisation, blood conservation, and a tolerance of anaemia, if you want to look for where your bangs for bucks are, you look for where you can bring the maximum change in the most consistent manner and most reliably. And there's no doubt that pre-operative hemoglobin optimisation is where we should be focusing. Because in fact, if the patient comes to theatre with an adequate or high hemoglobin, then 2 days later, the junior medical staff isn't confronted with the idea, well, will I transfuse the patient because their hemoglobin's 75? Because their hemoglobin won't reach the nadir of 75. So once you go out of the hemoglobin optimisation process, you come into progressively a greater area where it requires individual clinicians to either be educated, engaged, and on board. The operative suite is a good environment. It's a relatively consistent environment. The surgical group, the anaesthetic group, is a group that is certainly suitable to be educated, and certainly at the Austin over the last 5 years we've taken every opportunity we have in combined symposia with our surgical colleagues to talk about blood patient management. And as has been alluded to before, once you get out into the wards where you have the constant changeover of junior medical staff, short rotations, relatively infrequent exposure to the requirements to make decisions about transfusion, it's very hard to induce practice change in that group. This has been the best paper I've read in the last 5 years by Braithwaite. And we've seen it today. We've been sniggering about VMOs, we've been sniggering about doctors. We immediately resort to our tribe, or the opposing tribe, and the opposing tribe is the surgeons, and perhaps I'm being a little bit more subtle than showing Larry's photo. But it is a evolutionary process that humans have engaged in for millions of years. So why is it that we sit in a redesign forum and think that we'll be able to engage cultural change by getting people to act in a fashion that's different? So therefore, if we want to engage the VMOs, we have to understand how they make their decisions, and it's actually not their problem that they don't follow what we do. It's our problem because we actually aren't setting up the system to provide a way for them to respond in a way. And it's certainly totally predictable when you bring in change or challenge medical staff, there will be a resistance going back to that traditional educational point where the style. What I forgot to mention at that time was systems-based approach understanding is now one of the 6 core competencies of American physicians and specialists. It's been recognised as a core competency. So that would give you some confidence. In that article, it actually said, well, there's a problem. The universities don't know how to teach it, they don't really know what it is, and they don't know how to assess it. So the idea that there'll be a generational change in doctors is probably still a fair way away. The other interesting article, which is here, the second article, probably confirms what we've already known, and that is within healthcare professionals, there is a different level of willingness to engage in change. So therefore, if I want my process to work, or I shouldn't say my process, if I want the Austin process to be successful, clearly the nursing corps that are involved in pre-admission are going to be the most important allies that I can get on site. Another one of the things that's made me cringe over the last 5 years is the number of times I sit at redesign meetings and hear people talking about clinical champions. Now, it's true, in this article by Downton does also bring up the issue that not only do we not have systems-based training for medicos, actually the idea of medical leadership has no place currently in medical education. But okay, I think I'm a senior manager, I think I've got something to contribute, but I can't see myself as a white on a horse with shining armour riding in to fix problems as is often as portrayed, that there is this need for the messiah type clinical leadership. So what is true is if you have medical or senior medical opposition, your project won't work. But you don't actually need to have a zealous person leading your process. You need someone who's concerned and interested. The other daunting fact is that 80% of healthcare improvement programs fail to achieve sustainable outcomes. One of the divisions of the National Health has looked particularly at this and has devised a sustainability score that we've used on a couple of projects at the Austin, and I've actually used in the way I've assessed our hemoglobin optimisation process. It can be used as a predictive tool where you get key players to score, and it will highlight opinions in 10 different areas, and it will highlight either the deficiencies or strengths in your organisation, and you can look at your predictive score, and it can either give you confidence that you may have success, or it may actually tell you you've got fundamental issues that you need to correct before you proceed. And as I said, there's predetermined weightings in the 10 different criteria, and a score of over 50 gives you optimism, and a score below 30 means don't bother, or at least think very seriously about how you can change or fix some of the deficiencies. Now, none of these things are rocket science. It's not surprising that, okay, healthcare improvements are meant to improve patient care, so that's a given. If the project makes life more efficient, makes life easier for the healthcare workers, it's likely to be sustained if there is a benefit. Now, not surprisingly, patient blood management scores pretty poorly in this criteria because, in fact, it is a cost. Now, it's a cost that we don't really recur in Victoria because even when the hospital spends the money, we don't actually have a savings on our blood budget. So there's very little chance that you can see that beyond improving patient outcome that you're achieving anything apart from perhaps achieving your accreditation. If your staff believe that the process is credible, that there will be an improvement, if the process is an adaptation of your existing structures, it's likely to exceed. And if you have an effective system to monitor the progress, and that's the data, if you have prompt return of your data, then you are likely to have success with your process. Staff need to be involved in the initiation of the process, and right from the start I identified our anaesthesia resource nurses as the key people. So in fact, I actually got them to design how they thought the process would work. What I should also say is we've had one meeting. The haematologist, myself and the ARNs about 12 months ago sat down. We've had one meeting. We haven't kept any data, we haven't kept minutes, we haven't kept records. We communicate by phone, we check with each other, but we don't go into this ritual of getting the key stakeholders in the room, writing minutes and sort of perpetuating the process. Obviously, your staff engagement needs to be important. Management engagement needs to be important. And this is interesting because I'll show you the results of the scoring system which I did. And in fact, despite the necessity that accreditation is a high profile with the executive. We actually scored pretty poorly in this. So in fact, the people who responded didn't see that there was high-level management support specifically at a ground level for this kind of process. Clinical engagement is important, and obviously it's important for the process to fit in with your organisational strategy. And the staff have to be happy that there is adequate infrastructure and resources for the process to be sustained. As I said, 80% of healthcare innovations fail. One of the recommendations from the from the NHS group is that 50% of resources involved in the change process should be allocated to the monitoring and post-implementation support rather than just the initiation of the process. Now, every redesign process that I've been involved in focuses purely on designing a new process, and then there is an assumption that within the existing resources that are available, somehow there'll be monitoring of this process. So it's a fundamental mistake we make when we try to induce healthcare involved. And certainly with what's been discussed about medical involvement in this discussion is medical staff do respond to data. So if there is good data that's timely and it indicates that there is an improvement in patient outcome, then medical staff will engage. So reminding you again, we're still predominantly talking about pre-operative hemoglobin optimisation because it sort of bangs for bucks. Here we are. You've seen this template, and this is to tell you exactly what we're doing at the Austin. We started with the template. It identifies the major causes, major types of surgery, so obviously this is specific for us. The important thing is it actually highlights that you need to tailor this template for your own individual institution. So you know the scenario at the Austin. We do 23,500 procedures per year, which is the highest for any hospital in Melbourne. 16,500 are done at the main Austin campus, and 12,000 of them are elective cases. Of that, a quarter of those patients are seen in the pre-admission, the anaesthetic pre-admission process. And the majority of them are seen because of the extent of surgery, and therefore that fits in well with the NBA guidelines of major surgery, and major surgery patients require hemoglobin optimisation. And obviously the other reason why patients come to the pre-anaesthetic clinic is because they have comorbidities. So it's been relatively easy for us to make just a rule that routine bloods for patients coming to the pre-anaesthetic clinic for major surgery include the creatinine, CRP and iron studies as indicated by the NBA guidelines. I'll talk a little bit later. One of the problems that we've had to tweak is the fact that the NBA guidelines don't actually reflect surgical categories and urgencies. The other dilemma we had is should the iron studies be done when the patient is added to the waiting list or when the patient is surgically pre-admitted? And probably we do have the problem that surgical pre-admission is a little bit late, but when the patient gets put on the waiting list is probably far too early. And it would require significant resources to be able to monitor patients' hemoglobin and irons whilst they're on the waiting list. So what happens is all the patients who are seen in the pre-anaesthetic clinic, the anaesthesia resource nurse checks electronically before the clinic the results of the iron studies and CRP. If there are abnormal results, they're flagged to the anaesthetist who's involved in the pre-admission clinic, and there is a specific Austin algorithm in place that's been designed in consultation with the haematologists. We have a streamlined referral process. We have phone consultation, access to a haematology registrar. Obviously, communication is an important component in this process, so there's good liaison with the surgical units, and we have a standardised iron supplementation regime in process. Interestingly, it is important for you to know your own data and your own population. This is showing some data that we collected before our hemoglobin intervention process, and that was to look at 150 consecutive cardiac patients, showing that we had an incidence of anaemia of around 18-19%, but only a quarter of the patients who are anemic are iron deficient. The transfusion outcomes are probably what you would expect. The transfusion rate for coronary patients of mid-30s, and obviously the anemic patients have a higher transfusion rate and the non-anemic iron-replete patients have a lower transfusion rate. I suppose the one strange result is that the low transfusion rate in the iron-deficient males, and I think that might be an aberration, or it might simply be that, as was alluded to a little bit earlier by Larry, males have a larger red cell mass, and so it may be that they tolerate the hemodilution better than women, obviously. So when we said you can start with the NBA guideline, you need to design your own process, and I need to acknowledge Frank Hong, because he has been the main instigator of this algorithm. And one of the things that we've tweaked on the NBA guidelines is the assessment of what the patient's category is, because obviously that will indicate how much time you have to institute hemoglobin optimisation. So there is a group of patients that are not anemic, but who have depleted iron stores, that if they are expected to have a hemoglobin that may require transfusion, can go through a hemoglobin optimisation process. The anemic patients, if they can be delayed more than 30 days, as they're either Cat2 or Cat3 patients, they'll be referred to the hemoglobin clinic, which is we've piggybacked onto an existing hematology clinic. And if there is an inability to delay surgery, then we have an expedited mechanism how the anaesthetic clinic can order an iron infusion with subsequent hematology follow-up. Obviously, the thing that sits in the back of your mind is the concern that if we identify patients with iron deficiency anemia and then fail to exclude that they may have occult malignancy, that would be inappropriate management. Now, obviously, we have on the bottom fast-track mechanism to be able to get direct access to a haematology registrar and a way to expedite making the appointments. So, I told you about the sustainability score. Over the last couple of weeks, I've got a variety of key players to score it. I've got some of the haematologists, I've got the anaesthesia resource nurses themselves, I've got the anaesthetists. I deliberately chose some of the anaesthetists that I know that are kind of the supportive to change and innovation guys, and I also got some of the guys who just are very recalcitrant to any concept of change. I didn't bother to ask the surgeons. Partly because it's an interesting concept. These are their patients that we're working on, but they actually don't really have any engagement. The only engagement I had was in the first 2 weeks of setting up the process when we had a Whipple patient booked for a Whipples who had iron deficiency anemia. I was in the clinic, so I asked the anaesthesia resource nurse, check with the liaison nurse when the surgery is booked. I was told 6 weeks. And I said, that sounds strange for a Whipples. Is it really 6 weeks? So we checked with the liaison nurse again, and they said, yes, no, the case has been booked for 6 weeks. So I said, okay, let the patient run through the normal pathway. The patient can be seen in haematology clinic on Tuesday, and we'll take it from there. Something was a little bit wrong with the communication, because that Friday, the surgeon found out that instead of doing his Whipples on Monday, he was going to do 4 hernias. So he then immediately, in his tribal behaviour, called the head of his tribe, which is the professor of surgery. So I got the phone call from the professor of surgery saying, we've just been told that this patient's been cancelled by Peter McCall and we'd like an explanation. And I said, what are you talking about? And he said, this hemoglobin nonsense that you're doing. and I said, but I discussed all of this with you. I discussed it at the division of surgery. You're all told. and all that sort of stuff. And then obviously we worked out that there was this communication gap, and obviously the patient wasn't cancelled, so obviously we hadn't done things the right way. But the final thing was, and he said, and anyway, iron deficiency anemia is a surgical disease. And I said, if it's a surgical disease, how come you don't investigate for it? And obviously, the fundamental, apart from the tribalism, turf war, and, well, you can't tell me when I can play in the sandpit and all that sort of stuff, was clearly the surgeon was concerned that if they were to do a Whipples and then find out that they had missed a CA stomach or a CA colon, it would look very bad on the surgical unit. So we've had to make another provision, and that is if we have an anaemic patient who's general surgical, we notify the surgeons. And it also, as he said, and I want a surgeon to do the endoscopies. So there it is. So now here are our scores. To remind you, number one is the benefits to the institution greater than just a better patient outcome. And as I said, it's not surprising that score's low because, as I said, patient blood management costs us money. It actually doesn't really save us money in the current financial scenario. Interestingly, the other score which is low is the level of management and executive support, which I think is perhaps something that perhaps needs to just be done with better education. And the third thing that goes badly, and I could go into the detail between what each group said. For instance, the haematologists thought it was pretty good, and I think it's just because they were relieved that they haven't had to do a lot of extra work. It was the anaesthesia resource nurses who were most concerned that it was inadequate resources to maintain the sustainability of this process. So again, what sustains change is feedback. So what we now have in place is a database that all patients who have intervention with the hemoglobin optimisation is there. We now have a process that all patients who have hemoglobin interventions have their iron and hemoglobin measured on induction at time of surgery, and we will look at that data, and obviously we'll have the secondary outcomes of being able to look at transfusion rates. And certainly our early data confirms that we're picking up about a 15% incidence of anaemia, and that accounts for about 20 patients a month getting referred to haematology. Larry's touched on intraoperative blood conservation, and so I won't go any further, except to reiterate again, if surgeons operate better on JW patients or have less blood loss, what is that factor that actually brings that about, and why doesn't it happen for all patients? Anaesthesia, I think, is getting relatively informed. To answer what someone said about VMOs, education is an important thing. We've just about completed a audit on all intraoperative blood transfusions in theatre, and what's very interesting is we see two distinct trends, and that is there's a transfusion trigger for the staff anaesthetists, that's 8, and the registrars and VMOs, their transfusion trigger is 10. My next job will be to educate that group, and I think it's possibly that the VMO group may have old-fashioned views, and it may be that the registrars are overcautious, but with that kind of data in the right forum, it will be very easy, I think, to induce a change in the practice of the registrars and the VMO group. Another really good example of systems change has been the adoption of tranexamic acid. One thing is it's been relatively well supported by evidence, so I actually discussed with the orthopaedic surgeons about what we should do, and I actually left it for the orthopaedic surgeons to review the literature themselves rather than go and give them a talk, and then the head of orthopaedic surgery came back to me and said, look, we've looked at the evidence and we said, looks good, how do we do it? And it actually wasn't very hard to institute the fact that everyone who has a joint replacement at the Austin gets 15 milligrams of tranexamic acid as a systems-based approach. What has amazed me is how successful it has been. Albeit with retrospective cases, we had a retrospective series of 100 cases at the Austin, which had an average transfusion rate around 20%, with hemoglobin falls of around 40. We've then had a prospective series of 100 patients who have just received 15 milligrams of tranexamic acid on induction, and the transfusion rate's fallen to 6%. The hemoglobin fall has changed, and the other bit of data that I only got last night, and that is the discharge hemoglobin on the tranexamic acid group is 10 grams per litre higher than it was in the pre-tranexamic acid. So if you want to think about low-hanging fruit, this is about as low and easy a change that you can induce. To talk just very briefly about the idea of the acceptance of anaemia, as it's been alluded to today, it is a much, much more difficult thing that I don't think we really have got a lot of runs on the board yet. It requires education, but it's an ever-changing population of doctors that we need to educate. I probably would have contradicted Larry and say my understanding is that the level of training of junior medical staff in appropriate transfusion is pretty low. And I think Carol will attest that, she gives 1 hour lecture to the interns once a year about what is appropriate transfusion practice. So it's probably not as good as it could be. The other thing is one of the audit things for the guidelines is to defining appropriateness of transfusion. That is unbelievably difficult. I'm interested in this, but I still find it difficult to ascertain what is appropriateness of transfusion, particularly because it's the context. Non-bleeding patients are completely different than bleeding patients. Ward management is sort of probably a lot less supervised. In contrast, ICU probably is an area where we should be able to regulate a lot better, and certainly post-operative transfusion in surgical patient policy is different than medical. But as has been alluded today, certainly single unit policy is a highly successful thing. We have a single unit dispatch from our blood bank policy, but we don't have a policy that necessarily means that the patients will have a hemoglobin in between to ascertain their levels. So I remind you of my generic take-home messages about how you should go about implementing change in your hospitals. But it would be remiss of me when I've actually got a chance to sit on the soapbox to not go on about a few of the things that I've observed through this process. And none of these ideas have I've ever kept quiet before. I've mentioned them in multiple forums. Obviously, it's difficult for us in Victoria to establish patient blood management when we have the cost model that has blood products provided free. And until that changes, it's very hard for us to get engagement with the hospital. The other thing is we're not talking here about treatment of anaemia. And in fact, we're talking about hemoglobin optimisation to avoid transfusion in the perioperative period. So why is it that we accept a lower hemoglobin in women than men? Particularly when we know they've got a lower they've got a lower body mass, they've got a lower blood volume, and they are more likely to be transfused. So it is just illogical. I accept that a woman with a hemoglobin of 115, 120 is not defined as anemic, but she is at risk of transfusion. The other thing is we have addressed the issue of iron deficiency anemia. As I told you, all our data says that iron deficiency anemia is probably only a quarter of the causes of perioperative anemia. So what we should be doing for treating anemia of chronic disease, for us at the Austin, it is perhaps the next thing that we have to, because it's hard to maintain impetus in a program if we are doing all this work and what we are doing is identifying 5% of the patients and giving them some iron. The other problem is I think our data is going to show that even though we're intervening, we aren't particularly successful at increasing their hemoglobins. And I think it's possibly because we're still using oral more than intravenous. We don't have access to EPO, and at some stage, at a high level in Australia, we have to address the issue that we need to be able to get PBS access to EPO for peri-operative hemoglobin optimisation. Because in the scenario in which most of us work, most of the patients that we see in our clinic are Cat1 patients, so we have less than 30 days to get them fixed. So even an iron infusion may not be adequate. They may need EPO, and that's something we have to address. The other issue is that we don't have PBS access to some of the better, easier, safer forms of iron, and as such we have to rely on using iron polymaltose. And as I said, I make the comment, our patients come into two groups. We have the Cat1s that need to be sorted out straight away, and then we have our orthopaedic group that probably gets sorted out over 3 months. So therefore we need to have a very specific accelerated method of hemoglobin optimisation in the Cat1 patients. And then I'll just leave this as the last thing. We aren't even talking about emergency patients, because there are patients who are in the ward waiting emergency surgery who we could also be addressing how we optimise their preoperative hemoglobin as well.
It's a pretty rich field of issues. Questions? Comments? Is Karen Botting still here? Karen, do you want to talk about the funding issue raised by Peter, just while seeing you here? For the Victorian situation, obviously.
Thank you for that.
Pleasure.
The question really is about devolved blood budgets, because currently in Victoria the blood supply is funded entirely by the Department of Health, and the cost is not seen at a health service level. So what Peter is suggesting is that the cost be seen at a health service level, and also any of the savings. One of the things that we are having a look at is devolved blood budgets. No decision has been made yet on this, but it is being thought about.
Thank you.
The one comment, and I might not be as well informed about devolved blood budgets, is that it's still a lot more complicated, and there's still a lot more paper chase rather than the hospital's pharmacology budget. The hospital, if I give a business case to change a particular drug or something, the hospital knows exactly what their existing costs are and what their future costs might be, whereas to propose a business management, a proposal relating to blood, even if you have got the devolved budget, still not exactly the same sort of process.
Other questions?
When you develop your patient blood management guidelines in your organization, have you given a chance to have involve the consumer feedbacks on this? And if there is such, how did you do it?
I honestly would have to say no and no to that.
Final questions?
Can I just ask them, was that picked up, you've not long done completed accreditation, was that picked up by the accreditors?
I don't think it was.
Because we're in the process of implementing these guidelines in us, and when we're designing these guidelines in this process, we have thought to involve the consumer representative, and we will just want them to just go into the journey and the process. And we have stated our options and said that might be good, but I'm not quite sure if you have implemented it and we can adopt.
Well, I suppose hypothetically, one of the arguments for iron carboxymaltose is that when the patient would come to the pre-anaesthetic clinic and was identified as having iron deficiency anemia, we could actually administer the carboxymaltose in the clinic, and then the patient doesn't need to come back for a separate admission to our ambulatory care unit, which is already starting to complain a little bit about the number of iron infusions we're doing. So that would be something that would give us some impetus that said, well, it might be a little bit more expensive, but there's a real thing from the patients that are saying, well, to come back and to get it. And in fact, one of the problems is it induces a delay, because for us to then organise the iron, we decide one day the patient needs the iron infusion. It might take us 3 or 4 days to get it, and in a Cat 1 patient, that might be a significant thing. So in fact, for us to be able to administer the iron in the pre-anaesthetic clinic would be a significant innovation for us. Oh, now you get into another issue. The other thing which I've been told quietly is that iron infusions are actually a good little wee spinner. And in fact, for their cost, for their remuneration, in fact, doing more iron infusions is actually good for the hospital budget. Now, if in fact you did it as part of a pre-anaesthetic clinic, I'm not sure whether that would have costing implications. But to bring the patient back on a separate occasion for a 3 to 4 hour infusion is an inconvenience.
Unfortunately, we've run out of time. Are you here for lunch, Peter, that people can harass Peter? Just a closing note on a couple of those structural issues that Peter mentioned. The NBA is aware of the PBS issue and is taking it up with the Department of Health and Ageing. Us taking it up doesn't mean you'll see resolution quickly. I'd also mention we are working on a business case, because each of the states is different and the cost of blood is an issue, but there is a business case in terms of the amount of time patients spend in the wards and in ICU as a consequence of transfusion. And there are existing levers for a business case, and as part of those tools you will see business cases that you can potentially remodel, even given the problem of free blood. Peter, that was a thoroughly, I think everyone found that, I certainly found it a thoroughly interesting presentation of a major hospital in Victoria trying to implement PBM. And could you please give Peter recognition?